Chers collègues, membres de l'espace francophone de pneumologie, chers collègues, membres de l'association franco-libanaise de pneumologie, chers pneumologues et amis au Liban, j'ai l'honneur et le plaisir d'annoncer l'ouverture du congrès annuel de la Société libanaise de pneumologie qui se déroulera sur 2 jours et de façon virtuelle. اسمحوا لي كفي شوي بالعربي وهني كل الموجودين معنا اليوم من زملائنا بالسلامة أول شيء، وأشكرهم على كل التعاون مع بعضنا بهالزمن العصيب مواجهة التحديات الراهنة إيد بإيد. واضح إنه مجتمعنا الطبي اللبناني عم بيعيش حقبة كتير صعبة شكل فيها انفجار 4 آب ضربة موجعة وخصوصا لكتير مستشفيات وأطباء زملاء لنا. كذلك الأمر هالحقبة كتير يشوبها عدم الاستقرار والاضطرابات الأمنية والصحية، وانتشار وباء كورونا هو الأهم، صعوبات اقتصادية ومعيشية، وشح بالإمكانيات والتأمين بالموارد والميزانيات. كله هيدا بيخلينا نكون محبطين إن لم نقل يائسين بمجتمعنا. عدد من الزملاء كتار هاجروا سعيا وراء كرامة الطبيب وراحة باله. برغم كل هالظروف نحن بعدنا موجودين هون عازمين على مواصلة واجبنا الإنساني والتزاماتنا تجاه مجتمعنا ومواطنينا. مع بعضنا فينا نعمر حول الأزمة وما نخليها تغلبنا. Je voudrais commencer par remercier nos amis et partenaires dans l'organisation de ce congrès, les membres de l'association franco-libanaise de pneumologie et plus spécifiquement Dr Richard Timeri, Dr Youssef Zain, Dr Fadi Antoun, Dr Paul Morin et Dr Kabbani, qui sont des membres actifs et présents dans les comités scientifiques et organisationnels de ce congrès. Je les remercie aussi au nom de nos jeunes pour les 2 prix qu'ils offrent pour les 2 meilleurs posters présentés, et ceci pour la 2e année consécutive. En votre nom, je les félicite pour le 25e anniversaire de leur organisation. Nous vivons, comme je l'avais dit, une période très difficile, remplie d'incertitudes et de bouleversements. Baisse de budget parfois drastique, réduction de nos moyens entraînant malaise et démotivation au travail, départ de nos collègues. Tout ceci ne nous a pas empêchés de poursuivre nos obligations vis-à-vis de la communauté scientifique et de nos collègues et nous a amenés à insister encore plus à la réalisation de ce congrès. À cet égard, je voudrais saluer et remercier tous les membres du comité scientifique et du comité d'organisation qui nous ont préparé un superbe congrès. Je remercie notamment les présidents et coprésidents de ces comités, Dr Marie-Louise Koussa, Dr Georges Velekian, Dr Salah Zaineddine et la chère Dr Selim Bahnini, pour le double travail effectué vu que nous avons dû retarder ce congrès à plusieurs reprises. Je ne vais pas non plus oublier de remercier la chère Rada Bourgeili qui nous a aussi offert une aide précieuse cette année, même d'outre-mer. Merci Dr Bourgeili. Notre congrès offre plusieurs sujets de pointe présentés soit en langue française, soit en langue anglaise, avec une traduction simultanée. Le comité de pilotage a fait un choix innovant en nous proposant une variété de sujets qui touchent la plupart des maladies pulmonaires. Notre congrès, c'est aussi le salon professionnel. C'est le moment de l'année où vous trouvez réunies toutes les boîtes pharmaceutiques qui n'ont jamais cessé de nous apporter leur support dans toutes nos activités. Je vous demande d'être très nombreux aux divers symposiums de pointe qu'ils nous proposent et je les remercie infiniment. Je remercie aussi Madame Georgette Moines pour son dévouement et conscience professionnelle et enfin Infomed, la société organisatrice pour leur professionnalisme et leur engagement, en particulier Nancy, Firas, Mira et Joël. Notre congrès est un moment important pour la continuité de la société et de la profession, même s'il est virtuel. Nous souhaitons que ça soit interactif et le plus animé possible. Nous comptons sur votre présence et votre participation pour enrichir les points de vue et les discussions. La force du congrès et de la société dépend beaucoup de votre participation active. Je vous souhaite à toutes et à tous un excellent congrès.
Good morning, everybody. and welcome to the second day of our virtual Congress. I just want to underline the session of today, which is particular because of the multiplicity and diversity of the symposia presented during this session. And this, if any, underline the advances and the treatment now availability concerning asthma and underline the collaboration between the pharma and the scientific society at the level of the scientific knowledge. So I would like to thank them for their participation and the diversity of topics that they are going to tackle. Thank you.
Good morning, everybody. We will be starting the session 5 on asthma with the first symposium. I have the pleasure to introduce for you Professor Eric Batman. Professor Batman is a clinician, scientist, and pulmonologist. He is the founder of the University of Cape Town Lung Institute. He has made substantial contribution to global recommendation for asthma management and has published more than 350 papers in international peer-reviewed journals. Professor Batman was named as one of 6,000 of the world's most highly cited researchers in any discipline for the year 2006 till 2017 by the Web of Science. Who is better than Professor Batman to address to us a talk about resetting GINA recommendation? Dr. Batman, the floor is yours.
Thank you very much, and it's a great honor to be with you. Now, when we talk about asthma care, certainly there are 3 areas where we can make a difference to the morbidity and mortality of asthma. The first one is undoubtedly in severe asthma, and that's where the biologics are so important. We're able to do things in that very small group of patients with severe asthma. But that is only a small proportion of the morbidity. The second thing we can try and do is persuade people to take their maintenance treatment, because we have very good maintenance treatments. We have combination LABA ICS. We have other drugs that are good maintenance medications. But the critical unmet need is preparing patients for exacerbations, and particularly for worsenings of asthma. And this is what accounts for the majority of mortality around the world still, even in developed countries. So this is why it is important to say, when GINA revised its 2020 guide, it was all about the reliever. So let me take you through the thinking there. So in the 2020 recommendations for GINA, we have the preferred controller and reliever, and the preferred reliever is no longer the SABA, that blue inhaler that our patients know so well, and which is almost synonymous with the diagnosis of asthma, but instead we're recommending a low-dose ICS formoterol combination as the preferred reliever, which of course then can be used as the sole treatment as needed in steps 1 and 2, and we'll discuss that. But it also means that the same treatment may be used at steps 3, 4, and 5 as the maintenance treatment, the so-called maintenance and reliever. Now, this seems like a very radical change, and one asks, well, what about all the other medications that we've shown to be good? Well, the rationale behind this strategy is really got to do with patients, the way they behave, and the unmet need in asthma. So let's ask why. Well, firstly, because there is still morbidity and mortality, which is not falling. And it's not in the patients with the most severe asthma, it's patients with mild to moderate asthma. Secondly, SABA is neither logical nor evidence-based. It's not logical when we're dealing with an inflammatory disease to simply be using a bronchodilator. But the key behavioral things are that adherence with maintenance treatments are so poor, especially in mild asthma, and that patients are used to the concept of self-medicating, of taking their medicines when they feel they need it. And that's the one time when we have the opportunity to get effective treatment into them. And patients should be involved in self-management. And importantly, we need to start with mild asthma, because the lessons that patients learn about asthma in mild asthma carry forward into those that progress to more severe levels of asthma. But most of all, this change is because we have 15 years of experience with this combination reliever containing formoterol and ICS, most of it around formoterol budesonide. It's 15 years of very robust research, repeated, analyzed, reanalyzed, which comes up with the same answers, that that's a highly effective treatment. Because our issues, just to emphasize again, are that deaths in countries with good national health systems like the United Kingdom still attribute their deaths to inadequate treatment with inhaled steroids, that is poor maintenance treatment, and heavy and increasing use of beta-2 agonists. And this is a worldwide phenomenon. This data published this year from Sweden on SABA use by patients with asthma, a very large database, shows that with increasing SABA use comes increased risk of death from 2 canisters or more. Why 3 or more canisters? Because if patients are controlled, they should need only 2 canisters of SABA a year. If they're only taking 2 puffs twice a week, that would work out at 2 or maybe 3 canisters. And if they're using more than that, their treatment is failing and they need better approach. And it is clear from that analysis in Sweden that at all steps of treatment, increased use of canisters, more than 3 canisters a year, the higher the risk of exacerbations. Now, many patients live dangerously and rely on their SABAs only. So in this survey done in general practice in Australia, the researchers recruited 1,000 patients who said they were only taking SABA for their asthma. And then they compared it with a group of 1,600 patients who were also on a controller medication. And you can see when they analyzed the asthma control test that there were large numbers of patients who had very poor asthma control, very high levels of symptoms, and yet were relying entirely on their SABA medications. And in these patients, their risk of an urgent hospital visit, of an emergency room visit, of a GP visit, or healthcare utilization was 4 or more times higher. So these patients who rely on SABA alone, or who should be on maintenance but don't take their maintenance, are living dangerously, and they are responsible for the high mortality and morbidity which persists. Now, because we can now put electronic dose counters onto inhaler devices, we can know exactly when patients take their treatment and whether they take it at all. And so in this study, where electronic monitoring were used, the patients were on traditional treatment with salbutamol, that's the blue line, or they were on, as it was, budesonide formoterol, and they were meant to take 2 puffs twice a day. That's the black line. And what I want to show here is that in these 2 weeks before they had an emergency attack, that although they were taking their controller most of the time, they started taking more and more SABA because of increasing symptoms. And the striking features, at least for me, is the very high doses of SABAs that were being used. That horizontal dotted line is 16 puffs a day. So they were way above 16 puffs a day for as much as 10, 12 days before they came to hospital. They were excessively relying on the SABAs, and they delayed seeking help. But more important, it is our fault in a way, because we gave them no safety net. We gave them no plan to come sooner, to do better than they were doing. And these were well-educated patients. And sadly, it's because of this behavior that 2/3 deaths occur at home, while patients are relying on their SABAs to prevent a severe attack, or even prevent a hospitalization or even deaths. And so what we need is a plan for patients who are in this situation, a plan that is more effective than using a SABA. Now, our understanding of the biology of asthma helps us here. This is a study of children with worsening asthma, and you can see in the blue solid lines here are their symptoms. So you can see for several days before admission, their symptoms increased before they had to see the doctor, but at the same time, their exhaled nitric oxygen FeNO started rising from baseline to high levels. And then they saw their doctors, and then they were treated with cortisone, with prednisone, and their FeNO levels fell, and their symptoms gradually improved over the next 3 weeks. So when patients have symptoms, it reflects airway inflammation. And giving a bronchodilator alone at that point is not logical. So what we ask people to do is to take their SABAs until they get relief, or they have to come and get a dose of prednisone pills, and then the inflammation settles. And that's what we expect them to do. What is much more logical is to give a reliever that contains an ICS, so that the inflammation can be reduced and the lung function decline prevented. And indeed, that's how it works. This is data and analysis of the AHEAD study, where the 2 arms were either taking high-dose salmeterol fluticasone, 5,500 twice daily, so that's very high doses to try and prevent attacks, plus SABA. Or they were given budesonide formoterol in a lower dose, but used also as reliever. And you can see that as they start to need extra 4 puffs, 6 puffs, or 8 puffs a day, you can see that the only difference being the reliever almost halved the likelihood of an exacerbation after that first high reliever day. And we have done a similar analysis, which was published just a week or 2 ago in mild asthma. This is from the Sigma-1 study, which again shows the probability of an exacerbation 21 days after a first dose of high reliever. Now you can see when they need 4 puffs or 6 puffs or 8 puffs, you can see the difference between taking a SABA, the blue line, or taking budesonide formoterol, budesonide plus a SABA, that's the brown line, or taking only as needed treatment, no maintenance treatment, but simply reacting to symptoms. And you can see that there's a separation that's developing between the 3 treatments. And in fact, in the Sigma-1 study, there were no exacerbations in those who needed 8 puffs. The patients' exacerbations were prevented completely. So it gives us a clue that this approach is effective. Now, very recent evidence in this study shows what happens after a viral infection. And in the COVID era, we're interested in upper respiratory tract viral infections. Well, during viral infections, and this was an experimental infection in adult patients with moderate asthma, they developed a cold with the rhinovirus, which peaked at 5 days. Their asthma got worse at 7 days. And that's the typical pattern we're used to as clinicians. Patients say, I get a cold, then it goes to my chest, and my asthma gets worse. Well, what is happening in those 5 to 7 days is that the allergy, the type 2 inflammation also increases. So IL-4, IL-5, and IL-13 rises. And this is what the anti-inflammatory reliever addresses. It's addressing not the virus, but the consequences of the virus, its complex interaction with the type 2 inflammation, which increases. So the problem with asthma is not just how much maintenance treatment do I need, it is how does a patient respond when they are challenged by a cold, by anything that may precipitate an exacerbation. And that's the essence of requiring an anti-inflammatory reliever. And in this quite old study, which was done, was an analysis of the maintenance and reliever studies, looking at what happened after patients complained of a cold, a viral infection. So this is based not on virology, but simply on symptoms of a cold. And they followed what happened over the 2 weeks after the patient first complained of symptoms of cold. And there was a very striking difference in exacerbation rate, the number of cold symptoms that went on to an asthma attack, because the anti-inflammatory reliever prevented that. It didn't prevent the cold. They still got their rhinitis, but they didn't get the exacerbation. And that's the essence and the proof of the concept. So I'm sure you've all seen over many years these studies comparing maintenance reliever therapy versus a high dose of inhaled steroids plus SABA, or the same dose of maintenance therapy, or even a higher dose of maintenance therapy plus SABA. The point I want to make out here is that this analysis we published this year looked at steps 2, 3, and 4 patients. And it didn't matter what the comparison was, although a high maintenance dose helps to reduce that difference, it does not prevent that difference at all. And here is a meta-analysis of trials comparing a much higher dose of maintenance treatment versus a lower dose of maintenance and reliever therapy. And you can see that maintenance reliever therapy always outperforms high-dose maintenance treatment, because maintenance treatment is fixed, and it doesn't help you when the patient has an extra challenge which will break into an exacerbation. And so here is the other half of the Patel study. I've shown you the left-hand graph. I now show you the reliever and maintenance use in the patients on maintenance and reliever, and you can see that the levels of symptoms, the level of inhaler use was much lower because the safety net was in place. And remember, these are the patients who, in spite of taking extra, had an exacerbation that took them to hospital. Of course, many of these, far more patients in that category didn't even develop an exacerbation. Now, let's just deal with mild asthma to finish. You're all familiar, I'm sure, with the Sigma studies in mild asthma, where the comparison was in the blue step 1 treatment using a SABA-only treatment versus traditional step 2 treatment, which is budesonide, low-dose ICS plus SABA, all compared with only as needed anti-inflammatory reliever, that is budesonide formoterol. And you can see that clearly the 2 treatments with steroids were much better than the step 1 treatment, which is highly logical. And it didn't take very much as needed treatment to show the same effects between budesonide formoterol and budesonide maintenance. In fact, there were only about 3 puffs per week, 3 to 4 puffs per week was all that was required in the maintenance and reliever arm to avoid the need for a daily treatment with budesonide. Now, in a further analysis that we've presented in abstract form, we showed that in the pooled sigma 1 and 2 studies, in fact, for patients who had previously been on SABA only, so people who entered the sigma studies who had been on SABAs alone, actually maintenance, the reliever treatment only was more effective. And it was equally effective in patients who had previously been on step 2. So this really shows us that there's no point in simply moving people to earlier and earlier maintenance steroid treatment. They will do even better if they simply had a combination taken as needed. And exactly the same result was shown in the novel START. You can see in terms of the 2 endpoints, urgent medical care, courses of systemic glucocorticoids, the budesonide formoterol as needed was superior to regular daily maintenance treatment, and of course also to SABA taken as needed. And in that study, it is clear that the inflammation was equally effectively reduced. This is measured as FeNO, whether they took daily budesonide or whether they took only as needed budesonide formoterol. You can see the FeNO levels were elevated at the start and remained low throughout the 1 year of the study. Now, I think the importance of anti-inflammatory relief, for me, the key factor is what I tell my patient, because it's a much more coherent story when one is educating one's patients. What I say to my patients is, you have asthma. Asthma has 2 components. There's airway inflammation that causes spasm. When you get spasm, it means the inflammation needs to be addressed better. So the treatment of asthma is to treat both components. Here is a treatment that contains treatment for both. Every time you have a symptom, you need to take this treatment to address both. It gets away from this preference of reaching for a reliever because I've got bronchospasm, I must use my reliever, and they forget about the maintenance medication. It ensures, particularly in mild asthma, that they're getting effective treatment each time they need it. Now, Richard Beasley has done an interesting little exercise just to show the consistency of results right through from step 1 to step 5. If we take the left-hand traditional treatments, starting with SABA only, low-dose ICS SABA, medium-dose ICS LABA, then high-dose ICS LABA. And he says if we use maintenance and reliever, the anti-inflammatory reliever, in fact, treatment's very simple. And you can see the consistency of the results of the reduction in exacerbations achieved with this. So for most people, it might be step 2, maintenance, 1 twice daily as needed. For mild asthma, only as needed. And for severe asthma, one would increase to 2 puffs twice daily and as needed. And he's promoting this as a simplified form of applying what we've been talking about. And so if one has mild asthma, one starts with the anti-inflammatory reliever as needed, might have to increase or may have to decrease again, but at least there's continuity of care and of approach, which simplifies it very much for the patient. So I'm going to summarize and close to say there's growing evidence in favor to support anti-inflammatory reliever as the preferred approach across the spectrum of asthma severities. It does not do away with maintenance treatment. In fact, it is used on top of, it may be used on top of other maintenance treatment, but the key is the reliever. It does not replace the need for optimal maintenance treatment. There are many practical advantages of a single inhaler, and particularly in mild asthma where they don't need to take a daily treatment, which is so unpopular, particularly with adolescents. We're about to publish a paper showing that adolescent asthma is associated with adherence as low as 18%. The patients simply don't take their regular inhaled corticosteroid. This is an option which is bound to have a better response. And SABAs as monotherapy should be phased out and replaced with combination relievers. So that's the end of my talk, and I trust there might be some questions. I look forward to them.
Yes, thank you, thank you. Thank you very much, Professor Batman, for this clear and great presentation. I'll be waiting for the question from the audience. I'll start with one question from my side. Do you think, with all the risk you showed us about SABA, short-acting beta agonist, do you think that it's time to read about a black box warning as was said for the LABA 10 years before, or it's still not the time? And do you think that we need to ban this from the market, and how? Thank you.
Yes, those are quite radical solutions. I do believe there should be a warning because that would be consistent with what we know as a class effect. It applies to LABA monotherapy, it applies to SABA monotherapy. So yes, I agree with you entirely. And we might ask, why has it never been placed there? It's because it's such an old medication. We've never revisited. It's a bit like salicylates. You know, we only realized how much damage you could do with salicylates well into after using them for many, many decades. And so we need to catch up. I don't think a ban is practical. And there are situations where a SABA may be useful, particularly in the emergency room and in pediatrics there's still place. And we'd like to have the option. You know, it's not that it's poison, it's not tobacco, it's not poisoning patients, but what we're saying is it's not the preferred treatment. And we should be guiding people towards what treatment is better than using a SABA.
Okay. I have a second question, if you permit. Why do you think in GINA 2 there is still the option for the physician to choose between as needed reliever and maintenance treatment compared to ICS maintenance treatments with SABA alone? Because there is an advantage to use the reliever in this case as budesonide and formoterol.
Well, I think GINA needs to be two things. It needs to be global. It also needs to be science-led. And the reality is that step 2 treatment has been very effective in the past. There's nothing wrong with it. There's plenty of evidence that shows it's highly effective. And so we're simply saying, give people options, and they do have options. And of course, in many parts of the world, it's going to take some time for us to change the WHO and other global international guidelines to support an anti-inflammatory relief approach. But I can tell you it's happening. There are now, you know, more than 30 countries where it's in the national guidelines. The WHO have approved budesonide formoterol as an essential drug. And now it's a question of getting people to change their prescribing habits and to promote it within their countries.
Thank you very much. We'll stop here. We'll end this symposium. Thank you very much.
Bonjour à tous, je suis heureux d'être avec vous aujourd'hui. Avant d'introduire le docteur Juvelikian, permettez-moi d'exprimer mon admiration et mes félicitations aux collègues libanais pour l'organisation d'un congrès au Liban dans ces moments difficiles, voire même décisifs de l'histoire du Liban. Je voudrais aussi les remercier, surtout le docteur Zain Aoun, de nous associer à un tel événement. Sachez qu'en tant que pneumologue français, mais aussi libanais, nous partageons votre vécu difficile et nous espérons tous qu'on sortira de cette période la tête haute. Voilà, donc j'ai le plaisir et l'honneur d'introduire le docteur Juvelikian. Le docteur Juvelikian a fait ses études à l'Université américaine de Beyrouth. Il a complété sa spécialisation et son perfectionnement à l'Université de Rochester à Cleveland. Il est surtout le futur président. Il va avoir la charge de succéder au Dr Zenaoun à la présidence de la Société libanaise de pneumologie. Il est actuellement chef de service de pneumologie et de soins intensifs à l'hôpital Saint-Georges. Il est également professeur associé à l'université de Balaman et il va avoir la lourde tâche de nous parler de comment optimiser les avantages de la thérapie d'inhalation dans l'asthme. À vous, Dr Juvelikian.
Bonjour à tous. Thank you, Dr. Antoun, for the great presentation. I wish to thank the organizing committee and Novartis for the privilege of addressing this group of esteemed colleagues. And yes, you are correct. It's a difficult task to try to address therapy for asthma these days because we know the problems with asthma, but I'm going to try to give it a shot anyway in the coming 30 minutes. Because, well, fact is, asthma remains a very poor disease in terms of control. I'm going to only cite two major studies, the REALIZE study, where almost half the patients, 45% of the patients, had uncontrolled asthma according to the GINA definition, about 3,700 out of 8,000. INSPIRE study showed similar results to a large extent. So out of 3,400 patients, 51% had uncontrolled asthma by the asthma control questionnaire criteria. Furthermore, there is a disconnect between asthma control and patient perception. In other words, you talk to a patient, you tell them, how's it going? They say, everything is fine. You do some objective assessment and nothing is really good. Their asthma is not well controlled. As a matter of fact, 84% of the uncontrolled patients perceived their asthma as controlled in the REALIZE study. And close to 70% thought that their asthma was not serious. In the INSPIRE study, 55% of the uncontrolled patients perceived their asthma, again, as being relatively well controlled. And these are very worrisome pieces of data. Part of it, I think, stems from the fact that asthma is a disease that affects young individuals, and usually everything else being equal, when their asthma is controlled, they're fine. And even when they're not well controlled, they have a lot of reserve or enough reserve to label themselves as okay, while in fact they are in trouble. And this probably led GINA in 2019 to extend the need for controller medications even into the mild asthmatics, even into step 1, right? And this actually is the basis of my talk today. So why is it that we are in trouble? I mean, why is it that after all those decades, we're still struggling and controlling a condition that we know so much more about today than we did before? Well, first of all, there's this treatment mismatch for which we should actually upgrade components to improve efficacy, always without compromising on safety and with keeping in mind the benefit and the well-being of the patient. First, do no harm. And then, in the second part of my presentation, I'm going to talk about the misuse and adherence issues. This is an issue that's dear to my heart, and I think that I hope I can maybe share with you my angle of view on how to really approach asthma, because we do have a lot of medications out there. All of them are good enough. Some are better than others. This combination, I think, is better than most. I'm going to try to share that with you based on the data available. But at the end of the day, we are in trouble because people are not listening and patients are not doing what we're telling them to do and what we think is best. And hopefully we can bridge that gap in the coming 20-some minutes. So I'm going to start with the treatment mismatch and what we can do about it to introduce the triple combination of indacaterol, glycopyrronium, and mycophenolate. This is a new once daily inhaled combination designed to unlock the potential of inhaled asthma care. So it's 3 medications, an ultra-LABA, an ultra-LAMA, and a potent steroid. Put together in a device that's well known for previous years because of other combinations. And it comes with 2 strengths, right? So you have your medium strength and high dose. And the medium strength and high dose are based on steroids. And I'm going to also touch a bit on that in the coming few minutes. So we were talking about data and the importance of data, because at the end of the day, when you're trying to compare things, you have to try to use the available evidence to make it as your benchmark towards treating patients in the best way possible. Because what we do in our clinics on a daily basis, we kind of, if you will, run everyday studies with an N of 1, and we follow that person longitudinally to make sure that we are treating them in the best possible way, and that shows over time. The beauty of studies is that they can pool a lot of patients together and try to give us the answer that we want. So I'm going to go quickly over those 4 studies here. Quartz, which is a study that involved about 800 patients, symptomatic despite treatment with low-dose ICS. And the primary objective of the study was to show superiority of low-dose combination of long-acting or ultra-long-acting indacaterol LABA with mometasone furoate to low-dose of mometasone in terms of the trough FEV1 at 12 weeks intervals. There were other secondary objectives, the superiority in terms of ACQ-7 at 12 weeks. Other selected objectives were the peak expiratory flow and rescue medication use. Palladium study involved about 2,000 patients that were symptomatic despite treatment with medium or high dose ICS or low dose of LABA ICS combinations. So as you're actually witnessing, we're going through GINA, through the different steps of GINA in terms of achieving control, right? The primary objective, again, was superiority of the medium or high-dose combination indacaterol mometasone in terms to corresponding doses of mometasone alone in terms of trough FEV1 at 26 weeks. Secondary objectives, superiority of the combination to combined mometasone in terms of ACQ-7 at 26 weeks. And also other selected objectives with peak expiratory flow, rescue medication, asthma exacerbation, comparisons with high flow, salmeterol, fluticasone, which was a selected secondary objective. The Iridium involved about 3,000 patients. Here it looked at a more severe stratum of patients that require medium or high doses of ICS-LABA combinations for control. Again, the secondary and the primary and secondary objectives and other selected objectives were quite similar to the Palladium and Argon. Finally, about 1,250 patients symptomatic despite treatment with medium or high dose of ICS-LABA combinations. And it aimed at showing non-inferiority. This is a bit different. Non-inferiority of medium or high dose of the triple combination to high dose salmeterol fluticasone plus tiotropium, which is the benchmark LAMA that we see in most studies. And it was, tiotropium dose was 5 micrograms in terms of dosing, and looking at the AQLQ after 24 weeks. And the selected objectives otherwise were comparison in terms of trough FEV1, ACQ, and exacerbations. So indacaterol glycopyrronium mometasone, high and medium doses significantly improved lung function versus the indacaterol mometasone combination and high dose salmeterol fluticasone. And the improvement across the board was highly significant with a p-value of less than 0.001. Also, the triple combination, high and medium dosages, significantly reduced the rate of exacerbations versus high dose salmeterol fluticasone. The triple therapy had a faster onset of action compared with salmeterol fluticasone. This is something we know. We know from many other studies, and we know because salmeterol by itself, again, being a great long-acting beta agonist, is slow to initiate its action, about 15 to 30 minutes, and that has always been an issue because, as we all know, asthma patients, they love their rescue medications because they provide them with relief at the time when they want relief, and that's always been an issue. The key secondary endpoints were not met. However, all 5 arms demonstrated similarly high and clinically relevant improvement in change from baseline. But here again, proving that you had a p-value that was not significant ranging from 0.071 to 0.086. More patients achieved clinically important improvement in asthma control with the triple combination than with salmeterol-fluticasone. And the improvement was quite significant according to the change from the ACQ-7 with about 8% to 24% improvement in responders. Again, the triple therapy met the primary endpoint demonstrating non-inferiority, this is the Argonne study, on the AQLQ versus high-dose salmeterol-fluticasone plus tiotropium. And this is quite improvement. Again, we're talking about the primary analysis was demonstrating non-inferiority, and that should be within a 0.25 point change in the AQLQ score. Hence, in the medium dose, you saw a 0.038 decrease with the AQLQ with the triple combination versus high-dose salmeterol-fluticasone, whereas with the high dose, you had a 0.073 improvement with the AQLQ, both being non-inferior but not showing superiority or inferiority in that respect. The triple therapy high dose significantly reduced the rate of moderate exacerbations compared with free combination high dose salmeterol-fluticasone and tiotropium. Again, exacerbations being a very important element in the management of respiratory problems, asthma, and as we all know, COPD. Indacaterol, glycopyrrole, mometasone significantly improved lung function compared with free combination high-dose salmeterol-fluticasone and tiotropium, with a 96 ml improvement from baseline FEV1, trough FEV1, with the high-dose combination compared with the salmeterol-fluticasone plus tiotropium. Two words on mometasone, because again, the question is, why are we talking about medium versus high dose triple therapy? Because mometasone furoate is an ICS with high glucocorticoid receptor binding affinity versus other glucocorticoids. And here, I have to say that comparison with fluticasone, which is one of the most potent inhaled glucocorticoids, is also at play here. So mometasone has high receptor binding affinity. The potency of glucocorticoids is directly related to their agonistic receptor affinity. The higher affinity of mometasone to the human lung glucocorticoid receptor is predominantly determined by its high association rate constant, while its dissociation rate is slightly faster, and that's barely noticeable compared to with fluticasone propionate. So the efficacy of mometasone was shown in multiple studies, some of them reaching significance, but the aggregate was clearly in favor of mometasone being quite effective. And the comparators, well, what we use on daily basis, budesonide, beclomethasone, fluticasone as inhaled glucocorticoids. More importantly, and what matters to me as a clinician, for example, is the use of oral glucocorticoids. So reduction in oral corticosteroid requirement in severe asthma is something that mometasone can offer, and that's very important in terms of treating our patients with asthma. And I guess you can appreciate that a significant percentage of patients were able to completely get off their oral corticosteroid use, and that's quite impressive. In terms of safety profile, because that's something that we have to make sure we do not subject our patients with, and especially when we talk about steroids, I will talk about that later on when I discuss the adherence issues and what drives adherence with patients, especially with asthma. So in terms of safety profile, at all different levels, treatment-related severe adverse events, discontinuation due to adverse events, oral candidiasis occurrence, pharyngitis, headache, and dysphonia. All of them were not quite significant compared to other inhaled corticosteroids. But this is always a concern. That's something we have to educate our patients on when we talk about a combination that contains inhaled glucocorticoids. So overall, the triple combination and even indacaterol mometasone showed a favorable benefit-risk profile in the Platinum program that's combining the three palladium, iridium, and argon studies. And that gets me to the second part of my presentation, which I think hopefully will illustrate the reason why the introduction of a triple medication with the attributes that we have with this specific combination is interesting. So misuse and adherence issues. Of course, we all know this is actually something that we deal with on a daily basis. Drugs do not work in patients who do not take them. And this is true in all diseases, and I will show you that in the coming few minutes. But this is more true in asthma. And I think that has to do with a lot of different elements. I went over one of them with the population at risk, essentially, or affected population. But there are a lot of different other reasons for this statement to hold true in asthma in particular. So in the coming few minutes, I would like to reiterate the difference between the terminologies. So what is the difference between adherence and compliance? Are they the same thing? If not, what is different between the two? And what is persistence? Well, compliance, I'll start with compliance. Compliance, as we know, is when patients do what we tell them to do. So compliance refers to the consistency and accuracy with which the patient follows the doctor's instructions. And these were the good old days, maybe. I disagree, but I think it comes with the ethical principle of beneficence. So, as you know, there are many ethical principles. You have the principle of autonomy, beneficence, non-malfeasance, and of course, justice, right? So compliance is a reflection of the beneficence ethical concept. We are the experts. We tell patients what we think is best for them. They should follow what we do. Well, times have changed, and patients now are in the driver's. They've always been in the driver's seat, but they didn't know it, and now they do know it. So it's important for them to accept what we think is best for them. They should accept it, and when they accept it and are convinced, that's when they would adhere with therapy, and that would be the active and collaborative role from the patient regarding the prescribed treatment. And this nuance is greatly important in maybe reflecting why we have problems with our asthmatics today. Problem is even more branched than this, because even when you have patients that can be convinced and adhere, there is erosion that occurs. So persistence is affected because patients need to continue to use their medications as we tell them and instruct them to do. So persistence refers to the persistence in taking the prescribed medication regimen over the allotted time. And this is something that we know about from our pharmacists and drug reps when they tell us that patients, maybe when they fill their prescription, they don't stick with the medication. And this is the main reason why this is a case. In fact, even the definition of adherence is quite flexible. So we consider a patient to be adherent to therapy when he or she takes the medication 80% of the medication 80% of the time. So even that is a 20% reduction from what we optimally would want. And to tell you that it's not just a problem with asthmatics, a study in hypertensive patients from 2015 showed that non-adherence was 42% in one study. And this is hypertension. This is something that all people in the world know that is important to reduce the risk of cardiac disease, the risk of heart attacks and sudden death, etc. So even with something as vital as hypertension, in one of the studies, this study by Gallagher, 42% were non-adherent to the therapy. So what are the drivers of non-adherence? Well, you have to be aware of what the patient perceived. The perception of the need versus concern is what drives the education about the disease and is an important element about adherence. It has to be not just the cost. Cost is monetary or otherwise. Side effects, complications, complexity of therapy. So a lot of things are important when you talk about adherence. So the complexity is important because the more elements that go into the way the medication should be administered, the more likely we are to have erosion and no non-adherence. Lack of a primary care system. In Lebanon, we have an acute care system. So patients go to see us on an as-needed basis. So it's a patchy scheduled follow-up of maintenance and prevention. People do not come to us just to make sure things are okay. They come to us when there's a problem. So this is another issue why you can have problems with adherence. And of course, the clinical inertia that drives perseverance and persistence with inadequate treatment intensification in those situations. WHO has looked at non-adherence for a long time now, and they had 5 dimensions of non-adherence. They looked at the social and economic dimension, age, race, socioeconomic status, literacy, the cost of the medications. All of a sudden, this is a huge issue for us in Lebanon, and that we've become a low-resource country and we have a problem. Patient-related problems, forgetfulness. I'll talk about that in a bit when I talk about intelligent non-adherence. Treatment anxiety, misunderstanding of the instructions, the fear of dependence. Therapy-related issues like the complexity of the regimen, once a day, twice a day, multiple steps, etc. The duration of the treatment, side effects or adverse events, change in therapy that may be a reflection of our inability to achieve control and involving the patient in major changes on a frequent level or more than the patients can assimilate. They can be related to the condition itself, other comorbidities like depression, level of disability, patients, can they use their devices properly? Can they take their medications well? The severity of their symptoms, do they feel that there is a problem? And I talked about that when I first started talking about the perception of the problem versus the actuality of their problem, and how there is a major disconnect in asthmatics between the perception of the disease versus the actual control level of the disease. Other maybe issues, drugs or alcohol use or abuse. And of course, healthcare systems, patient-provider relationship. And if I were to drive one thing today through my presentation, it's exactly that. The better the patient-doctor relationship, the stronger it is, the better the communication, the better the adherence to therapy, and the better the compliance of the patient with what we believe to be best, and the better the outcome, no matter what we use. Lack of incentives. For example, for us here in Lebanon, if I were to say that I can achieve better adherence, but this is going to require spending an additional half an hour with my patient, can I afford to spend half an hour with a patient to achieve my objective? Delivery devices. So we're talking about the complexity of treatment, multiple mixed devices. They're complex, sometimes more than other devices. Poor initial training, we don't spend time to do that. And erosion, patients forget. Thankfully, one of the maybe silver linings of the technological advances is that today we can make it easier for patients to get retrained or re-educated about their device with maybe YouTube reminders or so on and so forth. We know about different devices. You have the metered dose inhalers, you have the slow deep inhalation spacers that improve delivery. These require priming, they require coordination. That's a big issue, so we have to select our patients properly. I think one of the silver linings of patients maybe abusing their short-acting beta agonists is that I personally think a lot of them don't even know how to use it well. So they waste most of it, which is good, instead of getting all the side effects. Delivery devices such as the soft mist inhaler, as the Respimat inhaler, which needs slow, deep inhalation. It's excellent for the delivery to the lung. However, it requires priming and requires coordination and has multiple steps involved that we need to educate our patient on its proper use. Other delivery devices like the dry powder, multi-dose inhaler, many of them on the market. You have the single-dose inhaler like the breeze inhaler or the hand inhaler, where you have to change the dose every time you use it. They require a quick force for inhalation, so you have to also select your patient properly and make sure that they can generate a quick force of inhalation. and they may require activation of the following dose. And this actually got Gina in 2019 to specifically talk about optimizing the inhaled control medication. Confirm that the inhaler is suitable for the patient, check and correct inhaler technique with a physical demonstration and teach back method, check inhaler technique again at each visit, address intentional and unintentional barriers to adherence. So asthma adherence is a major problem in chronic disease management. Adherence to asthma ranges from 30 to 70% depending on the studies, and I only listed a couple here, but there are many out there. In more recent studies, 22 to 78% of asthma patients adhere to their prescribed medications. So we do have a big problem with maintaining our patients on the treatment prescribed for the duration and the way that we believe is best for them based on their specific cases. A couple of words on intelligent non-adherence. This is a very nice study that I urge you to read. It's a bit old, but it still holds true today. And it tried to talk about the concept of what patients can perceive and how they usually rationalize their non-adherence. So I'll give you an example. So a patient lives, for example, in Beirut, goes into the mountains in summer or in the weekends, and on Friday, and it's difficult, and that patient goes to the mountains, and when he gets there or she gets there, he or she forgets that, remembers that they forgot their medication, that inhaler in Beirut. And it was hell to get there, so they say, fine, hope nothing happens, I'll just skip that dose tonight, and tomorrow morning, without fault, I'm gonna go down and get it. So they go without that dose. The following day, they wake up and they're fine. And they start thinking, maybe I don't need that dose, that second dose today. So maybe I can do it once a day, not twice a day. Or maybe even better, let me see if I can skip it altogether and see what happens. And they test themselves. And in asthma, as we all know, to get an exacerbation doesn't happen immediately. It's something that can take a few days to occur. And that's what can cause patients to misuse their medications and do it in a logical, rational manner. And that's what you can refer to as intelligent non-adherence. And nowadays, with what's going on in Lebanon, it's even more tempting because they can stretch their medication. Instead of their medication lasting them a month, it can last 2 or 3. And that is an issue that we need to be aware of and educate our patients on. So it has to do, again, with balancing necessity versus concerns. Concerns arise from their beliefs about potential negative effects. I mentioned steroids. Again, this is always an issue, steroid phobia. And the necessity. When we have high necessity, high perceived necessity, and low perceived concerns, you have good adherence. When we have low perceived necessity or high perceived concerns, we will have low adherence. And that is very important, and it's something we have to reiterate over and over again when we talk to our patients about their asthma management plan, because it's a plan. It's not just one medication or one device.
3 minutes more.
Thank you. So when we talk about non-adherence, you have to put all this together. This is our job, to educate our patients and to take into consideration the complexity. So a simple device is better than a multi-step device. Once a day is better than more than once a day, twice a day or 3 times a day. One medication better than 2 medications. One device better than 2 devices. The highest effectiveness is more important because, again, it makes our patients comply because they actually are feeling better. Reducing low necessity by explaining to our patient, educating them on the importance of adhering to their treatment plan. High concerns from our patients, they should be alleviated by us. That's why I said that the better the contact with my patient, the better off we should be. Side effects, same thing. Cost, of course, is a big issue. So the less complex, one medication instead of more, all this is going to drive the cost down and help with adherence to therapy. So in conclusion, despite many inhaled asthma treatments, every 3rd asthma patient on inhaled therapy remains uncontrolled. And that's a fact that I hope I got across today. Triple therapy and dual therapy with indacaterol, glycopyrronium mometasone versus indacaterol mometasone. These are 2 new once-a-day inhaled combinations designed to unlock the potential of inhaled asthma care. They reduce treatment mismatch by reducing exacerbations versus high-dose salmeterol fluticasone, a leader in the treatment of asthma even today. Improving lung function and asthma control versus salmeterol fluticasone and loose combination salmeterol fluticasone antiotropium. Again, they reduce misuse and adherence issues. 50% of patients are unable to use their inhaler properly, even with training. We should be, it's our job as clinicians to properly select our patient for the proper treatment. The therapy is delivered via the breathehailer, which provides dose confirmation, reduce the risk of critical error compared with other devices. And with that, I will close and I will thank you for your attention.
Thank you, Dr. Juvelikian, for this excellent and clear presentation.
Thank you.
There are two questions. One from Dr. Hélène Abiot. She asked you, do you think that in case of exacerbation, marked approach with budesonide formoterol can be used with this triple form of maintenance therapy?
Yeah, thank you for the question. It's an excellent question. I do not recommend it for many reasons. Number one, you're actually using two long-acting beta agonists, and that is going to drive the side effects up without major benefits. Second of all, budesonide is a steroid that I like. It's got a low side effect profile, but when you add it to a patient who is on a potent steroid like mometasone, you're probably not going to be adding much benefit. So my personal bias is that if you find that your patient is using the triple device and is adherent to its use and using it properly and still not getting the results you wish, I suggest you re-evaluate the triggers, whether they are well taken care of, the triggers of asthma, like allergies or irritants or so on and so forth. Second, make sure that the patient is using the device properly. Third of all, make sure that you find other reasons that for non-adherence that I talked about, intelligent non-adherence. And if you find that they're not getting the benefit, you either can add to it and as needed short-acting beta agonist, or change the device altogether and use maybe salmeterol, formoterol budesonide in the MART approach individually, which is also well described even in GINA.
Thank you. I have one personal question.
Yes, sir.
Do you think that GINA recommendation can be applied in children under 12 years age, for example?
Yes. Yes, they can be applied under 5 years of age. And I think today with the GINA is, they expand on that in the document. So you're more tuned to that than I am. But I believe that any treatment available today in inhaled form that aims at controlling asthma is going to be very well justified in even in children below the age of 5 years, and at all costs better than ending up with oral steroid regimens after regimens, or ending up in the emergency department with a severe exacerbation. So the answer is yes. I think it's always about cost benefit, but it's clearly in the favor of using inhaled therapies to maintain control.
Thank you very much. Thank you.
My pleasure.
Rebonjour à tous. C'est un véritable plaisir pour moi d'introduire le docteur Zeina Aoun. Au-delà d'être une amie avec des valeurs professionnelles et humaines exceptionnelles, elle a eu le courage et la lourde tâche de tenir la barre de la Société libanaise de pneumologie pendant ces 2 années très difficiles. Et pour cela, elle a droit à mon admiration la plus sincère. Dr Zeina Aoun est une pneumologue, tout le monde le sait. Elle est professeure associée à l'Université Saint-Joseph. Elle est présidente de la Société libanaise de pneumologie et elle a participé à de nombreux travaux scientifiques nationaux et internationaux. Elle va nous parler de comment simplifier aujourd'hui la gestion et le management de l'asthme. À vous, Dr Aoun.
Je remercie au début Dr Anton pour cette introduction. Good morning, dear colleagues. I'm glad to discuss simplifying asthma management with you for the next 25 minutes. I hope that you enjoyed these 2 days of LPS Congress and that topics meet your expectations. These are my disclosure for this presentation. I will tackle some aspects already discussed by Dr. Juvelekian. We are insisting about controlling asthma. Asthma patients are recurrent patients in our clinic. Asthma is a common and a potentially serious chronic disease that imposes a substantial burden on patients, their family, and the community. According to current asthma guidelines, when we want to treat our asthmatic patient, we think first of all about achieving control, preventing exacerbation. Control of asthma symptoms, as well as the minimization of future risks, including exacerbations, fixed airway obstruction, and side effects, represent the central target in asthma management. Fortunately, asthma can be effectively treated, and most patients can achieve good control of their asthma. When asthma is under good control, patients can avoid troublesome symptoms during the day and night, need little or no reliever medications, have productive physically active lives, have normal or near normal lung function, avoid serious flare-ups like exacerbations or attacks. We also, as doctors, need to minimize adverse effects from asthma medications. Since the beginning of asthma management, the control of asthma cannot be achieved without inhaled corticosteroids containing medication. Yet, challenges still arise due to lack of compliance, like well discussed by Dr. Juvelekian in the former presentation, and asthmatic patients are still having uncontrolled asthma symptoms and recurrent exacerbation. One of our goals of having good asthma control is by using a potent inhaled corticosteroid with minimal dosing per day in an easy-to-use device. Beclomethasone dipropionate was introduced in 1972 as the first synthetic corticosteroid asthma controller medication administered via the inhaled route. This was a major breakthrough that freed asthma sufferers from the fear of the adverse events associated with chronic systemic corticosteroid use. Since then, a further 7 inhaled corticosteroids have been approved for clinical use with a range of glucocorticoid receptor selectivity, potency, physicochemical properties, and pharmacokinetic and also parameters and inhaler formulations option. I think it is important that we acknowledge budesonide propionate to highlight that since the availability of this molecule, many advances have been made in the development of newer molecules. What is the difference between available inhaled steroids in the markets? It is good to know the evolution in their structure. These inhaled steroids undergo many structural modifications to become more selective to glucocorticoid receptors. These structural modifications result, besides the greater specificity for the glucocorticoid receptor, on a longer duration of receptor occupancy and less association with non-target steroid receptors. Inhaled corticosteroids molecules are known to vary in their pharmacodynamic, physicochemical,
Mais il faut qu'on soit
and pharmacokinetic properties, but are widely regarded as therapeutically similar. Potency differences between inhaled corticosteroids are thought to be overcome by administering larger doses of a less potent drug to achieve therapeutic equivalence. Is this assumption correct? Potency is determined by selective molecular affinity on glucocorticoid steroid receptor, which results in lower dose to achieve expected anti-inflammatory effects of inhaled corticosteroids. Like we see in this slide, where only 100 micrograms per day of fluticasone furoate that have the highest receptor affinity can do the job. So no need to increase inhaled corticosteroid dose. This slide will show the glucocorticoid receptor affinity of various inhaled corticosteroids in the market, with fluticasone furoate the most potent. To illustrate the importance of glucocorticosteroid receptor binding affinity and the risk encountered with increasing doses of inhaled corticosteroids on, for example, adrenal suppression, I will go with you rapidly over a study done by Neil Barnes and colleagues, funded by Glaxo and published in the British Journal of Clinical Pharmacology in May 2020. They wanted to compare the airway potency, systemic activity, and therapeutic index for 3 inhaled corticosteroids that differ in glucocorticoid receptor binding affinity, physicochemical, and pharmacokinetic properties. Serum cortisol concentration time profile at baseline were similar between all treatment groups. And at day 42, in the right of this slide, there was no indication of significant cortisol suppression with fluticasone furoate vilanterol at the 2 doses, 100 and 200, or placebo. However, 24-hour serum cortisol concentration were notably lower in the prednisolone group compared with fluticasone furoate and placebo groups, indicating the validity of the study for measurement of effect on hypopituitary axis function. Non-inferiority to placebo was demonstrated for the primary endpoint, 24-hour serum cortisol, after 6 weeks of treatment with either lower and higher strengths of fluticasone furoate. They assessed in a randomized placebo-controlled study the dose response for topical efficacy via airway responsiveness to adenosine 5-monophosphate AMP challenge, causing a 20% fall in FEV1, what we call AMP PC20, as on primary objective. And the second primary objective was to characterize the dose response and relative potency for fluticasone furoate, fluticasone propionate, and budesonide on 24-hour plasma cortisol suppression on treatment from pre-dose on day 6 to pre-dose on day 7. The third endpoint was to assess the therapeutic index for every inhaled corticosteroid studied. Fluticasone furoate, I remind you, fluticasone propionate, and budesonide in asthmatic subjects. The therapeutic index is the ratio of ED20 cortisol suppression, those at which 20% cortical suppression is reached, over ED80 for AMP PC20, those at which 80% of the maximum AMP PC20 is reached. AMP-PC20 value for fluticasone furoate dose of 200 micrograms exceeded the response for any fluticasone propionate or budesonide doses as shown in this slide. And at their lowest approved dose for asthma, fluticasone furoate provided 3.5 to 4 times more airway protection than fluticasone propionate or budesonide. All the three molecules produce some degree of systemic activity as measured by the 24-hour weighted mean plasma cortisol suppression as shown in this slide. This study provides evidence that inhaled corticosteroids may differ in their therapeutic index. When compared at therapeutic doses, fluticasone furoate in green on this slide with higher anti-inflammatory activity and greater lung retention has greater airway potency with lower systemic activity than fluticasone propionate and budesonide, which exhibit lower airway potency with more systemic activity. Fluticasone propionate is in blue and budesonide in red on this slide. At the end, what we want from an inhaled corticosteroids molecule, we wanted to have a low oral bioavailability of the swallow weight component. We needed to be eliminated completely with high systemic clearance. We agree on the importance of the high affinity and specificity for glucocorticosteroid receptor, and we wanted to stay longer in airways. In adults and adolescents aged more than 12 years, not adequately controlled with inhaled corticosteroids and as needed inhaled short-acting beta agonist, fluticasone furoate vilanterol is indicated for the regular treatment of asthma, where use of a combination medicinal product, LABA and ICS, is appropriate. 2 strengths of fluticasone furoate are approved for the regular treatment of asthma. Fluticasone furoate vilanterol can be initiated at 100 once daily, then stepped up to 200 once daily according to asthma control. Physicians may wish to initiate it at higher dose in patients who require a higher dose of inhaled corticosteroid, like the very symptomatic or severely uncontrolled. The higher dose is 200 over 25 micrograms. This is the device provided with Relvar. It's a multi-dose dry powder inhaler designed to be used by patients across a range of disease severity in both asthma and COPD. Now, let's look at how to choose the most suitable treatment. In order to do so, we need to use, and it is very important, shared decision-making with the patient caretaker to discuss the following. The preferred treatment for symptom control and for risk reduction, the patient characteristics or phenotype. Does the patient have any features that predict differences in their future risk or treatment response compared with other patients? Like if he's still smoking, history of exacerbation, or have blood eosinophilia. Are there any modifiable risk factors or comorbidities that may affect outcomes? What are the patient preferences? What are the patient goals, beliefs, and concerns regarding asthma and medication? This is the importance of the education of the patient and doing a plan with him. We also have to take into consideration practical issues. Can the patient use the inhaler correctly after training? The adherence to treatment. How often is the patient likely to take the medication? The cost to the patient. Can the patient afford the medication? There is a clear distinction between population level national guidelines and patient level treatment decision. How well asthma is controlled? Uncontrolled asthma remains a major global problem, and this study also was mentioned by Dr. Juvelekian before. the David Price survey of 8,000 patients from 11 European countries aged 18 to 50 years with more than 2 prescriptions in the previous 2 years was conducted. And he found that 45% respondents had uncontrolled asthma. Exacerbations were common, with 44% reporting use of oral corticosteroids for their asthma in the previous 12 months, and 24% of respondents had visited an emergency room, and 12% had been hospitalized for their asthma. However, more than 80% of patients considered their asthma to be controlled. Of those who experienced an exacerbation requiring oral steroid, 75% regarded their asthma as not serious. This illustrates the difficulty of reaching the same result in real-life study compared to randomized control study. So, is this good enough? When I first saw that study about Relvar and heard GSK saying that Relvar is as efficient as any other available medication, I thought that it is not good enough. I needed to see the superiority and advantage of this drug. I wanted better, and I found that in the GSK study on superiority, which is an effectiveness study reflecting what you do in your daily practice, the next few slides present this data from a unique real-world study to investigate the effectiveness and safety of fluticasone furoate in every daily clinical practice combined to vilanterol. This is the Salford study. Some of you know it, published by Woodcock on 2017. Why did they conduct this study? They did so because Relvar has attributes such as the once daily dose, the 24-hour efficacy, high patient preferences, the easy-to-use device with low critical errors that can play out in everyday clinical practice. All these advantages were the basis of the hypothesis of the study. This was a large study that included over 4,000 patients. The criteria for inclusion is that they have to be adults, evaluated by their GP, and have diagnosed asthma. They also have to have been on inhaled corticosteroids or combined therapy. 73 of these patients were uncontrolled. When the patient came into the study, he was randomly given Relvar or the usual care. Usual care can include all kinds of inhaled corticosteroids or combined therapy available in the market. The Salford lung study evaluated the effectiveness and safety of asthma medication in everyday clinical practice symptomatic patients on inhaled corticosteroids plus or no ad-LABA initiated treatment with fluticasone furoate vilanterol at the 2 doses or continued optimized usual care for 52 weeks. Electronic health records were used to collect data, clinic visits at start and the end, with phone call in between at weeks 12, 24, and 40. The aim of the study was to analyze the level of asthma control at 24 weeks for patients using Relvar versus patients on usual care. To fully understand the process, I remind you that populations were defined as follows. All subjects enrolled in population, intent to treat population. This population is defined as all subjects who have been randomized and received at least 1 prescription of study medication, fluticasone, vilanterol, or usual care. This and primary effectiveness analysis population is defined as all intended to treat population with NACT total score less than 20 at baseline as recorded in their folders. Primary endpoint for asthma control, it's the percentage of patients with asthma control test ACT higher than 20 and or increase of more than 3 points at week 24 for the primary effectiveness analysis population patient with an ACT less than 20 and at randomization. An increase in 3 points was chosen as a composite, and it has been clinically validated as a meaningful, clinically important differences in asthma control as measured by ACT. If we look at the results, 74% of the population reached control after 24 weeks with Relvar, so they have ACT more than 20 or an increase of 3 from baseline versus 57 on ICS. If Relvar provides a significant improvement, which was consistent over time and maintained for 52 weeks with no tachyphylaxis, neither tolerance to their product. This result is consistent when compared with inhaled corticosteroids. In the primary effectiveness analysis population, the odds of achieving asthma control for subjects who initiated treatment with fluticasone furoate vilanterol are twice the odds of achieving asthma control for subjects who continued treatment with usual care. This difference is statistically significant at the 5% level. This asthma control persists at long-term analysis. 25% more patients improve asthma control at 6 months after initiating this treatment. And in another sub-analysis of the Selford study, published 1 year later, they evaluate quality of life measured by the Asthma Quality of Life questionnaire at 12 months of randomization in the study. 27% more patients improved quality of life with Relvar. This study in COPD patients who take account on critical error rates on using devices were critical error rates were consistently low with Ellipta. This finding was statistically significant for all comparators. The low error rate was 5 to 14%, and the difference reached statistical significance for all comparators. There was discus acualar, MDI, turboalar, handy-alar, and breathe-alar. So, in conclusion, exacerbation is a key factor in uncontrolled asthma, and control remains the key goal of asthma management. Uncontrolled asthma is a major global problem contributing to the burden of asthma for both the patient and healthcare system. It is vital to identify the different patient groups and phenotypes to improve therapeutic options. Individual assessment of symptoms and risk factors leading to individualized treatment decision, not one-size-fits-all approach. Regular dosing of inhaled corticosteroid-containing medication is the treatment of choice for establishing asthma control. The inhaler device is vitally important to assure asthma control. Relvar is an administered once daily inhaled corticosteroid long-acting beta agonist with 24 hours continuous efficacy. It is available in an easy-to-use device with fewer critical errors than other commonly used inhalers. Fluticasone furoate is the newest and most potent inhaled corticosteroid available at the moment, and with a wide therapeutic index. These 3 final slides provide additional information about Relvar provided by the pharmaceutical company Glaxo. And here I want to thank you, and I'm ready for any question.
Merci, Dr. Raun, for the excellent presentation and clear presentation. I have one question. Est-ce que vous pensez qu'il y a encore une place pour les nébulisations de corticoïdes chez les enfants ou chez les adultes? Ou est-ce que, avec les dispositifs actuels, on peut s'en passer?
Moi, je pense que chez les enfants, c'est toujours indiqué parce qu'on n'est pas sûr que les enfants vont prendre des inhalations profondes avec ces différents devices. On peut les essayer, et sinon, et surtout les petits enfants. Donc, il y a toujours une indication pour la nébulisation chez les enfants et chez les vieux qui n'ont pas un bon flux aérien, un bon débit aérien pour aspirer sur ces devices. Bien qu'il a été étudié qu'avec certains devices, on a besoin de moins de débit pour inhaler, donc moins que 60 litres. On peut voir et évaluer le débit aérien de notre patient. Il peut y avoir toujours une indication chez les sévèrement atteints avec des VMS vraiment très bas et une force musculaire qui n'est pas adéquate.
Merci beaucoup. Merci pour tout, pour cette excellente présentation. Il n'y a plus de questions. Merci, docteur.
Merci. Merci à vous.
Hello, everyone. It gives me great pleasure to be the moderator for the coming session. It's a symposium sponsored by AstraZeneca, and I'll be really honored to present our dear speaker, Dr. David Jackson. So Dr. Jackson is a consultant in severe asthma and eosinophilic lung diseases and the clinical head for the Guy's Severe Asthma Center. He qualified from UCL Medical School and undertook his respiratory training at the Royal Brompton, UK, and St. Mary's and Hammersmith Hospitals in London. During this period of training, he gained a Master of Science degree in allergy as well as a PhD, focusing on the role of respiratory viruses in asthma exacerbations. David moved from a clinical academic position within the National Heart and Lung Institute at Imperial College to take over leading and developing the severe asthma service at Guy's and St. Thomas NHS Foundation Trust in 2015. With this, I would like to give the floor to Dr. David Jackson. The floor is yours.
Thank you very much. It's my pleasure to talk to you today from London. I'm sorry I'm not with you personally, but I just want to send my best wishes to everybody. We were very, very sad to see the terrible explosion in Beirut recently and all the devastation and loss of life. So our thoughts are with all of you at this difficult time, and hopefully you will rebuild your beautiful city there very soon. Now, today I wanted to really talk to you about severe asthma. And we're in a very fortunate position now that we have therapies that are really transforming our patients' lives. And I'm going to talk to you a little bit about this. We don't have too much time, so I can't do it in too much detail, but I hopefully will cover the main points where we are. So this is a picture, as you can see on the screen now, of Guy's Hospital in London. It's in the middle of London with the Shard building behind, which is the tallest building in Europe, which is just across the road. I have disclosures, which are that firstly, this is obviously an AstraZeneca symposium. I am on advisory boards for most of the companies that develop asthma therapies and do educational events. Just very briefly, before I get on with the asthma side of things, in the United Kingdom, the Department of Health set up a series of specialist centres for asthma in the last 10 years or so, and these were responsible for really delivering all the care for severe asthma. Of the therapies that we now use, the biologic therapies, are very, very expensive. I felt that it was inappropriate that certain physicians who didn't really have very much experience in severe asthma were prescribing therapies like this, these biologic therapies. So it was decided that only experts in specialist centres, where they see hundreds and thousands of patients with asthma, would be really responsible for this, where a multidisciplinary team could review the patients, assess them fully, and so on. And so all the other hospitals in the region then refer their patients to these specialist centres. And you can see in London there are 3 centres like this. On the right, on the map of the right, you can see the red dot, which is us in the centre of London. And all the other hospitals, which are the black dots, then refer their patients to us. And so we look after a population of between 4 and 5 million people, which crosses this area. We get about 800 referrals each year with suspected severe asthma. And currently we have about 500 patients on biologic therapies. So severe asthma is essentially a condition of exaggerated and uncontrolled type 2 airways inflammation. What do we really mean by this? Well, just I'm sure this is familiar to many of you, but just to go over it very briefly anyway, the airway epithelium, the lining of our airways, is not simply an inert barrier to the outside world, immunologically active. So when it encounters allergens, various allergens, if in a patient who is sensitized to those allergens, the epithelium becomes activated and releases the classic epithelial-derived cytokines, IL-33, IL-25, TSLP. In time, there are dendritic cells, antigen-presenting cells that sample the environment and present that antigen or allergen to naive T cells, which become polarized to Th2 cells. And these Th2 cells produce three of the classic Th2 cytokines, which are IL-4, which is the most important cytokine that tells B cells to make IgE, IL-13, which is the most important cytokine for airway hyperresponsiveness and mucus hypersecretion, and IL-5, which is the most important cytokine for eosinophilic inflammation. IL-5 tells the bone marrow to make eosinophils. It leads to the activation of eosinophils. It prolongs the life by delaying apoptosis of eosinophils, and so. Now, this branch of type 2 immunity is really what we think of as the allergic eosinophilic pathway. The idea that through allergen presentation, you get inflammation in the lungs. At the same time, we appreciate that many patients we see are very eosinophilic, but have no evidence of allergy at all, or really it's very minimal. Yes, they're a bit sensitized to grass, pollen, or house dust mite, but their total IgE is relatively low, 150. It's not really a main driver of their very significant symptom. We know that respiratory viruses, in particular, rhinovirus common, and pollutants as well, the epithelium and drive these T2 cytokine production from the epithelium in the same way, but rather than the Th2 cells, we know that the type 2 innate lymphoid is very, very important. There's not as many of the type 2 innate lymphoids of the Th2 cells, but on a cell-per-cell basis, they produce about 100 to 200 times as much IL-5 and IL-13 as the Th2 cell. What these cells don't produce much of is IL-4, which is why you don't really get the kind of B-cell IgE kind of level. And we really think of this side, non-allergic or non-atopic branch driving eosinophilic inflammation. At the same time, we know that in many patients, and non-atopic inflammation, it can be quite difficult, dominant driver for the eosinophilic inflammation in the lungs. But I'm going to tell you a little bit about how to help with that. We've known for a long time that actually eosinophilic inflammation is at the center of uncontrolled. The paper I'm showing you from 1975, so 45 years ago, in the New England Journal of Medicine, the sentence from the abstract reads, the total eosinophil count reflects asthmatic activity, useful for regulating the steroid dose, and for the early detection of exacerbation. The first paper that clearly defined the eosinophil count as a biomarker of risk in terms of exacerbations, a biomarker to help OCS stewardship, the idea that you don't overtreat with steroids if there's not sufficient inflammation there, and that it can be a biomarker of ongoing day-to-day control. 40 years after this, David Price published this very important paper in Lancet Respiratory. And this really showed you that in a very large population, this is a UK-based study, primary care-based study, that the more eosinophilic you are, and this is eosinophil count, the greater the risk. The greater the risk of exacerbations, the greater the risk of having poor asthma control. And you can see this very clearly, almost in a dose-responsive way. As you cross a blood eosinophil count of approximately 300, so your risk increases in a stepwise fashion. Now, fortunately, we've got fantastic biologic therapies that can really target eosinophilic inflammation, both driven by allergic inflammation and non-allergic inflammation. What I don't want to do is show you lots and lots of phase 3 data. What I want to do is show you some real-world data. This is more appropriate for as clinicians looking after severe. I'll tell you why. So why do we need this real-world data? If we look firstly at some of the phase 3 data, the omalizumab phase 3 data from Nick Hanania, published in 2011. This is the largest of the omalizumab randomized control studies, and this is the only one, according to the Cochrane review, that was actually in severe asthma. What I What I want to do, though, is just show you something over here. What you can see is that in the patients randomized to placebo, 57% of them, no exacerbations during the 1-year study. In fact, combining the two top figures here for placebo, 83% of so-called severe asthma, maximum of 1 exacerbation in the year after giving placebo, really highlighting that in truth, even though this was meant to be severe asthma, the vast majority of patients probably didn't have. You see this across all the biologic studies. Let me show you for mepolizumab. This is Mensa study on the top, the MUSCA phase 3b at the bottom. In the Mensa study, 45% of the patients randomized to placebo had no exacerbations. Only 13% had more than 2, which is really the kind of category we think about when starting to use biologics in our patients. In the MUSCA study, it was even worse. There was 59% had 0 exacerbations when given placebo. Only 6% of the whole MUSCA study reflected the kind of patients we use these. What really does this tell us? Well, this paper by Hecking, published in Jackie in 2015, really summarizes this problem. He showed that in the Netherlands, this Dutch study, that across the population, 24% of patients treated as severe in a step 4-5 treatment, medium to high dose ICS lab. And of these 24%, 17 of 24 poorly controlled. So poorly controlled severe asthma, on paper, these are severe asthma patients. But actually, when their adherence was corrected to inhaled steroids, which was often poor, when their inhaler technique was optimized, actually only 3.7% remained uncontrolled and what really were severe asthmatics. This is important because it's the 17% that are actually recruited to phase 3 studies, where it is the 3.7% patients we end up giving these biologics to. Only a fraction of the ones who end up in these studies. This is why there's a problem with phase 3, which is why we need to look at real world. So let's look at some real world. Well, the largest study for omalizumab tells us a few interesting things. Almost 3,000 patients in Japan. The top is the exacerbation rate in the year before commencing omalizumab. Bottom bar is the year after, and each color exacerbation frequency. You can see that those 42% of patients who, despite having the right phenotype of severe allergic asthma, given omalizumab, continue to have at least 2 exacerbations on treatment. In fact, you can see that more than a quarter, 28%, had 4 or more courses of steroids, 4 more exacerbations, despite the right phenotype. This really highlights a significant issue, which is that for many of these patients, targeting IgE doesn't actually solve the problem. The problem seems to relate to the eosinophilic inflammation that the allergic inflammation or non-allergic inflammation drives forward. Interesting is when we did a post-hoc analysis of the phase 3 studies for benralizumab, which is the anti-IL-5 receptor, takes away the eosinophils from the airway. That it doesn't matter what your IgE is in terms of how you do when you get this treatment. You can see here again, there's 2 interesting things. The first is the gray, which is placebo. What does this tell us? Well, it tells us that it doesn't matter what your IgE is. IgE itself is not a biomarker of risk. The risk of an exacerbation when given placebo was the same whether you had an IgE of 200 or 2000. IgE is not a biomarker of risk. And what this other thing this tells us is that when you give a patient benralizumab targeting the eosinophil rather than IgE, the effect is the same whether the patient had an IgE of 200, 1000, 1500, 2000. It's all the same. And this is very different when we look at the eosinophil as a marker. Because in the placebo arm, you can see as the patient becomes more acidic, the exacerbation rate goes up because it is eosinophils, not IgE, driving exacerbations. And given benralizumab, you can see that the exacerbation rate falls, and the higher the eosinophil count, the greater the effect size. Now, we then have lots of therapies that are available to us to target both allergic and non-allergic inflammation. Omalizumab, of course, was the first, which targets IgE. Then we had mepolizumab, which targets the IL-5 cytokine, benralizumab that targets the IL-5 receptor, and dupilumab that targets the IL-4 receptor, which is with IL-4 and IL-13. The question then is, well, which one do you choose? Because in many patients, they are eligible or appropriate based on their more than one. I wanted to study this and specifically looking at patients that had allergic eosinophilic inflammation, patients who could have either omalizumab or mepolizumab or benralizumab. Because when we took patients and divided them, and this was 157 patients, a year of treatment, when we divided them according to whether they were eligible for omalizumab and mepolizumab, benralizumab, so that's the eligible column here, n equals 65, or those that were eligible for anti-IL-5 treatment with mepo or benra, but not eligible for even the p-values, outcome measures, so percent reduction in exacerbations, percent reduction in maintenance OCS, change in lung function, symptoms of control, symptoms of quality of life, and so on, that actually there was no difference. The effectiveness of drugs like mepolizumab and benralizumab that target the eosinophil is exactly the same whether or not you're also eligible for omalizumab based on perennial sensitization, an IgE within the dosing range, and so on. The difference between mepolizumab and benralizumab. Mechanism of action is slightly different, and it's an important difference. Really, the difference relates to the fact that because mepolizumab targets the IL-5 cytokine, get rid of all the eosinophils. And this is because the eosinophils respond to more than just IL-5. There are other cytokines that are also relevant for eosinophil survival. Whereas benralizumab, because it targets the receptor, the IL-5 receptor, any cell expressing the IL-5 receptor is rapidly apoptosed without any release of the granules. So you really get rid of every single eosinophil and any other cell expressing the IL-5 receptor, which is really basophils as well. What happens, is there any difference? Does it matter whether you get rid of all the eosinophils or just, let's say, half of them with mepolizumab? Data we published earlier in the year in CHEST of mepolizumab, real world. This is 100 patients. You can see here with different outcome measures, the baseline data for the 1 year before commencing and the 1 year after. This is 1 year data. So you can see that overall there's a very good improvement with mepolizumab, with an exacerbation rate that dropped from about 4 to approximately 2. In fact, this was a 54% reduction in exacerbations, which is a very nice improvement in symptom control of 0.53 for ACQ and 0.86 with quality of life. And there was no difference with lung function. This relates to benralizumab. With benralizumab, this is in press at the moment, also in CHEST. We actually see, rather than 54%, we see a 72% reduction in exacerbation. This is 130 patients who've completed 1 year of benralizumab. So here you go from 4.9 down to about 1.3 with exacerbation. And steroids on average could come off. I'm going to show you the data in a moment. The symptom score, rather than improving by 0.5, could actually improve by 0.75. And quality of life, a very good improvement. We also actually saw a significant improvement in lung function as well, which we did not see with the mepolizumab cohort. This is the data shown graphically. You can see the exacerbation rate dropped, rather than going from about 4 to about 2, which is what we saw with mepo, from about 5 to about 1. Very quick improvement in asthma control, which is evident by the second dose, which is at same for quality of life on the bottom left, and lung function. So you see a very quick improvement in lung function, which is then maintained at almost a completely static level for the whole year. With steroids, which is really often the most important benefit these patients get, prednisolone is toxic. Often these patients have to take prednisolone at a varying dose of between 5 and 20, 25 milligrams every single day to maintain control. When they start a drug like benralizumab, they can come off it in many cases. And you can see here that already if we look at the bottom graph, in weeks after starting benralizumab, half the patients could completely stop their prednisolone. and the vast majority by a year were off steroids altogether. For more information about all of this, you can I refer you to our paper in Chest in Press at the moment. What's interesting is when we actually look at the open label extension studies for mepolizumab and benralizumab, so this is the extension studies of the phase 3 data in the you see a numeric difference between the mepolizumab results and benralizumab results, which actually mirrors what we see in the real world. So here is the Cosmos study, which is the 1-year extension for mepolizumab. And you can see that the patients who had mepolizumab during the phase 3 and the 1-year extension had an exacerbation rate of 0.9, and 54% were exacerbation free in here. There's 414 patients. The same study was done for benralizumab, which was a study published in Lancet last year. Rather than 0.9, actually the exacerbation rate was 0.46 numerically. And rather than 54%, there was a 74% of patients who were completely exacerbation free. Again, suggesting there appears to be a benefit of benralizumab compared to mepolizumab purely on this indirect treatment comparison. Why might this be? Well, we know from the original data it only gets rid of approximately half the eosinophils in the airway and in the bone marrow. We know from the DREAM study, which was the phase 2b for mepolizumab, this graph is from that study, that the different doses of mepolizumab led to a different level of reduction in sputum eosinophils. The higher the dose, the better the reduction in airway eosinophilia. And the dose we use for mepolizumab, that licensed dose, is 100 milligrams subcutaneously. These doses here are intravenous doses in the phase 2. And you can see that the 100 milligram dose subcut, by the way, relates approximately to 75 milligrams intravenous. And you can see that at that dose, we're not really getting rid of all this airway eosinophils compared to higher doses. We also know that, as I mentioned before, that because the IL-5 receptor is also expressed on basophils, and basophils also produce T2 response to the epithelial-derived cytokines of IL-33 and TSL. By also taking rid of these cells, getting rid of basophils, you are likely to lead to a lower level of T2 cytokines in the airway, which is a positive. Dupilumab. So I know that in Lebanon, dupilumab, I think you're going to be getting it very soon. Dupilumab is an excellent drug for eczema. Really life-changing for many patients with atopic dermatitis. It's also a very good drug for asthma. It's different from the others because it targets IL-4 receptor. What we know from the data published is that it really works in exactly the same patients that the IL-5 drugs work. You can see this here. Unless you have eosinophilic inflammation, it doesn't work. If you have a normal pheno, it doesn't work. And so this really reflects the idea that you have to, at the very least, have active inflammation, active T2 inflammation. It's no good just having a high pheno if your eosinophil count is low, because you can see here from the eosinophil count, it simply doesn't work unless it's elevated above 300, which is the same category as mepolizumab and benralizumab. Now, pheno is not measured in the phase 3 studies for mepolizumab and benralizumab. So although the narrative for dupilumab is, well, if you have a high pheno, you should use dupilumab, this is not quite fair because pheno is not measured in the phase 3 for mepo and benra. So we have done an analysis which is currently in review at a journal to look at this. What we did was we took the patients combined mepolizumab and benralizumab, 230 patients. And we divided all of them into quartiles based on their pheno at baseline. The lowest quartile had a pheno between 0 and 31, the second quartile 32 and 52, the third quartile 53 and 77, and the fourth quartile greater than 77. You see that the exacerbation rate here, the reduction in exacerbation rates with mepolizumab and benralizumab was exactly the same, irrespective of which quartile pheno was in. So those with the highest pheno, more than 77, had the same response to those who had a pheno of, let's say, 30 or less than 30. This is same is true for with reduction in prednisolone. Also the same for change in asthma control or change in quality of life. There was no statistically significant difference between those with the highest FeNO, those with the lowest, but it is interesting to note that actually those with the highest had the best improvement, numerically at least, with asthma control symptoms. If we just look at the benralizumab, what we also see, very interestingly, is that there is a reduction in FeNO in those patients with the highest levels of FeNO when we use benralizumab. And this is not really known about, and this is why we're publishing it at the moment. The mechanism behind this is because eosinophils themselves produce IL-13. FeNO is just simply a marker of IL-13. We know it's IL-13 because if you block IL-13 with lebrikizumab, which is anti-IL-13, FeNO drops very, very quickly to normal levels. So this tells us that when we look at FeNO levels at baseline and at 1 year, that's what these respond to here, baseline 1 year, baseline 1 year, there's a significant reduction in those with the highest FeNO. And actually it's very interesting because at 1 year, what it really shows is it comes down to approximately the same level of FeNO, irrespective of where you started. To summarize, real-world data is important. Phase 3 studies appear to mainly recruit moderate rather than severe asthmatics.
We have 1 minute, sir.
From the real-world data for benralizumab, it really demonstrates that there are very, very good reductions in exacerbations of at least 70% and large improvements in control and steroid-sparing prednisolone doses. And these fantastic results are independent of allergy, whether they're allergic or not, or whether they're also eligible for omalizumab or not. And it's also independent of FeNO. As much as the FeNO is high, you get just as good a result when you use benralizumab as if the FeNO is lower, as long as they're eosinophilic. And there's no safety signals at all to date relating to eosinophil depletion. And for those of you who are concerned about safety, I'll just refer you to this article here we published earlier in the year. I did this with Stephanie Korn from Germany and others, Samir Mathur from America, which really reviews, it's a very extensive review article going into all the safety data to date in benralizumab across asthma, COPD, hypereosinophilic syndromes, and so on. Just finally, my last slide is just to show you what we do at our center. Benralizumab for severe asthma is first line for severe eosinophilic asthma, unless they have bad eczema as well. If they have bad eczema, we use dupilumab first line because it's very good for both eczema and asthma. We don't really use omalizumab very much anymore, but when we do use it, it is only really in severe child onset young patients where we're very confident that it's allergy driving the symptoms mainly. But if the patients need steroids every day, prednisolone every day, we don't use it, we use benralizumab, because in those patients we found that omalizumab actually doesn't work as well. We use dupilumab second line to benralizumab, and this is not because I'm saying benralizumab is better than dupilumab, but the dosing is every 8 weeks for benralizumab compared to every 2 weeks for dupilumab, so it's so much easier for the patients. It's less difficult and it's not so horrible for them to have an injection every 8 weeks than it is every 2 weeks. And we also change from benralizumab to dupilumab if there is a poor response from nasal polyposis. We know that many patients on benralizumab respond very well to in terms of the nasal polyps, but sometimes they don't, and we might switch them in that. I'll stop there and delighted to take any questions. Thank you very much.
Thank you, sir. From the audience, we received no questions. However, one of my colleagues in the room here raised a small concern or just a clarification. We know that for a long time, we kind of been using omalizumab almost exclusively in Lebanon and the north of the world being the only available biologic. And most people were satisfied with the results, of course, with a very close patient selection and knowing, picking for the atopic. How would you comment on that in view of the data, and how would we place omalizumab in that effect?
So thank you for the question. Definitely omalizumab is an effective agent. So I showed you the phase 3 study from Nick Hanania, which showed there was a 25% reduction in exacerbations in that phase 3 study. with good improvements in other outcome measures as well. In fact, the only thing it didn't really show was an improvement in patients needing maintenance prednisolone every day. So the most severe patients didn't work if they were on maintenance prednisolone. So there's no question omalizumab works. But we know that the newer biologics appear to work better. And so when we're faced with a choice between omalizumab and mepolizumab, or omalizumab and benralizumab, or omalizumab and dupilumab, if based on our experience and based on the percent reductions in the controlled studies, randomized controlled studies, omalizumab would probably now be fourth in terms of efficacy in severe asthma. That's not to say it doesn't work, it's just to say that others are better. And so our experience is that we now really it's gone into fourth place after, I think the top two, in my experience, are benralizumab and dupilumab, based purely on my experience. And I think the published data, it supports that notion.
Okay, thank you, Dr. Jackson. That was a very informative and comprehensive talk. We thank you for your time and your efforts. And with this, we'll move to our next talk.
Thank you.
Hello, good afternoon again. And it's my pleasure to present Dr. Nadim Kanj. Dr. Nadim Kanj is currently an assistant professor at the American University of Beirut Medical Center. He is the director of the smoking cessation program at the same center. He is involved in clinical work, teaching, and research. He has shared, moderated, and lectured in several national, regional, and international conferences, and he is also an ex-president of the Lebanese Pulmonary Society. Dr. Kanj is going to talk again about the severe allergic asthma, the other phase of allergic asthma, with 17 years of targeted omalizumab treatment. Dr. Kanj, the platform is yours.
Thank you. Good afternoon, everybody. I would like to thank the LPS for organizing this really enlightening scientific topic, virtual one. I mean, it matches international conferences. I would also like to second what Professor David has said about our colleagues in the hospitals that suffered. I thank God for their safety. We are very sorry for their losses, but we are very encouraged that they are rising and working again. The scientific committee has done a great job, as I said, in the topics. I have some, remarks on the organizing committee. Well, this year, we didn't have any gala dinners, any lunch breaks, any sightseeing. It was all virtual. But thanks, they put us some stretch, 10 minutes of stretch. So this is probably, something that we hope we don't see it in further future conferences. Going into this, I would like to keep on with the same difficult, confusing little bit topic, the severe asthma. And severe asthma should be differentiated, as all of you know, from the uncontrolled asthma and from the difficult to control asthma, and then we come to the severe asthma. So I would like this to be clear because I'm doing my best to simplify this coming presentation. What I'm going to discuss is the severe allergic asthma. So each one of these terms has its own meaning and importance. So if they are severe, they are not uncontrolled or probably difficult to control, because the previous lectures discussed this. They are allergic, atopic, and they are asthmatics. So this is what we are going to discuss by now. And interestingly, we have changed our logo. And I did not know about this except a few days ago when I started preparing this lecture. So I'm glad that we have a new logo now of the LPS. So I borrowed some slides from some other presentations to say that asthma has many faces. This is the famous portrait by Pablo Picasso, The Weeping Woman. So asthma is a heterogeneous, but it can be packed by themes. So we have to approach the identification of phenotypes in asthma, and hopefully they should be unbiased approaches. This is the allergic multimorbidity. Actually, we have various perspectives in looking at this cartoon. So we have to know that allergic rhinitis, for instance, commonly by different studies, occurs with other diseases. We have the nasal, many of them have nasal hyperactivity, like we have bronchial hyperactivity. Up to 60% of patients with allergic rhinitis have allergic asthma. And a minority, relatively speaking, have atopic dermatitis. So going nowadays to phenotypes and endotypes, this is the era of translational research that is going forward with the research on asthma. Genes and the environment will make our phenotypes. So the ideal combination of these two categories will create our phenotypes of asthma. And there are two major risk factors that contribute to severe asthma, and they will modulate our immune responses. GINA is well known to all of you. What I am now presenting in this cartoon, probably a lot of you know. We have to confirm the asthma diagnosis. We have to know that we are dealing with severe asthma, not difficult asthma. And then we have to identify the phenotype, namely the allergic asthma, the atopic asthma. And as the previous lecture has said, there is the eosinophilic asthma and versus the type 2 low asthma, which has not been so far studied a lot, and we don't have excellent medications so far. So close to 4% of patients with asthma have what we call severe asthma. That is, they require the GINA step 4 to 5 treatment, in spite of their good adherence and the inhaler use. And this is very important. So there are comorbidities and confounders that alter our asthma phenotypes. We have phenotypes, we have endotypes. The phenotypes are known to most of you. Anything practically can make us, environmentally, our genes and so on can affect our phenotypes. The endotypes, really we have a lot of omics and omes, genomics, transcriptome, proteins, metabolites, lipids, microbes, and so on. All will play with our endotypes and will affect our disease subtypes. This is a famous slide, famous picture, photo from the recent Schottler in the chest in March, which starts with the genes and the environment causing our phenotype, then going into our immune responses, transcriptomes, genes, metabolomes, proteomes, which figure our endotypes, and the thicker the these lines, the more importance, and then going to what we are interested now, the elevated IgE and the eosinophilia. And these, based on these two biomarkers, there is the target now asthma therapy. Interesting also study a few years ago that chronic rhinosinusitis phenotypes and asthma. This is really an interesting study which I wanted to present. I mean, it clustered these patients by tissues from their nose to 10 clusters. And there is some line between them. The first 4 are a little bit much better than the last 6. And if we go down, then we find that the last 3 are the most difficult. And these will have the IL-5, the IgE, and the Staph aureus also related IgE, eosinophilic cationic proteins, and they will have the combination of the CRS with nasal polyposis and a high percentage of asthma. Okay, also, severe asthma, interestingly, by a recent study, can be classified by a chest CT scan. So there are studies on this severe asthma. Wherever we can classify it. Let's go ahead and classify it. And this interesting study by Kim 2 years ago proved that there are 3 CT scans airway types. The large airway type, which is the majority of the patients with severe asthma, have a higher peripheral blood eosinophil count, more bronchial wall thickening, more mucus plugging, and bronchiectasis. The small airway type, which more or less might be similar to the ACO, the asthma COPD syndrome, is definitely not that much in percentage. We have a higher fixed airway obstruction, mostly males, smokers, and so on. The near normal type, they are the ones who definitely will need less oral corticosteroids. Again, more and more severe asthma can be classified not only by CT scan, but also by a sputum microbiome. So we have, using the unbiased clustering based on sputum microbiome profiles, showed that severe asthma can be classified into 2 phenotypic clusters. The ones with the less severe asthma and the ones which includes the neutrophils and the macrophages, and together with the subsequent and bacteria and with subsequent airway obstruction. Asthma pathogenesis. This is also an interesting cartoon to tell us, simplify our life, hopefully. So we have the triggers and the allergies. We have the allergic asthma, which is our topic today. And this will include the IgE, interleukins, and eosinophils, in addition to the eosinophilic asthma, which will contain only the eosinophils and the interleukins. So we are going to see what's going on in the allergic asthma today. Type 2 inflammation definitely is underlying our lung pathophysiology. We have the healthy airway, the airways during the severe asthma. We have a lot of troubles that goes inside our bronchus and will lead to the difficult situation of the asthmatics. Type 2 inflammation is found in 50 to 70% of patients with severe asthma. So again, a little bit of a repetition of the slide of the mechanisms of type 2. The viruses, bacteria, and others will cause the damaged epithelial cells. This will go to the dendritic cells, and this will go to the alarmins. And this cell, remember this cell, the innate lymphoid cell, this cell might have a future by an antibody or something. It's being more and more studied nowadays. This cell might be important in the future, but keep it in mind for the coming few years. Then, as expected, we have the Th2 also activation going to the B cells. The B cells will secrete the IgE. The IgE will go to the mast cells, and all the granules will be degranulated, and we'll have the whole cascade of vicious cycles in asthmatic symptoms. So identifying type 2 airway inflammation in asthma definitely has these 3 current biomarkers. One of them is the total and specific IgE. All type 2 asthma, as said, are not the same. This is from the fascinating most recent review by Sally Wenzel in the Physiological Review. I think everybody should read this article. This is a very, very interesting article that elaborates on everything in asthma practically. And we are going to talk mostly about the mild corticosteroid, which has also the IgE, and as known, the treatment is only the inhaled steroids, as said, and the early onset moderate to severe corticosteroid treated modestly responsive allergic asthma. The mediators include the I4, 13, the 5, and of course the IgE. And the treatment will entail the anti-IgE, which we have experienced for more than 17 years, probably 20 years or a little bit more. So the total specific IgE, the pheno, and the eosinophils are the 3 currently approved biomarkers. Periostin, others may be mentioned somewhere, but we have to deal with this. and they are driven by the activities of IL-4, 13, and IL-5. However, when we go to this slide, we discovered that these cells here, the B cells, the mast cells, the dendritic cells, and the rest are the ones on the top of the list, and they are inhibited by the omalizumab. Okay, so we have predictors. Do we have predictors of response to type 2 biologicals? Yes, we have the other anti-interleukins, but we have also the first one for 20 years, the anti-IgE, and the strong predictors of response to the anti-IgE, interestingly, is as expected, the exacerbation history and the serum eosinophils. So the more the merrier, the more you have even pheno or eosinophils or something, the more anti-IgE will work. And this is quite interesting in the field of omalizumab. So uncontrolled asthma, as said, exacerbations leading to more exacerbations and leading to a COPD probably like picture, and this will lead to a long-term complications. So the airway mast cell basophil may be the primary target in mild, moderate, severe allergic asthma. This is the, the mast cell, which will be activated when the IgEs come and on these receptors, and this will be the mast cell that will be degranulated, and it will cause immediately the noxious agent release, mostly histamine, TNF-alpha, and this will cause to sneezing, itching, runny nose, watery eyes, wheezing, and bronchoconstriction. After minutes, we will have also the leukotrienes and the prostaglandins, and later, over hours, we will have the cytokine production, the IL-4 and the IL-13. So it is in the mast cell, which has the IgE receptors, that starts the bad degranulation of all its mediators that are going to cause this asthmatic serious situation. Okay, so what do we do? When we give the anti-IgE, we are working at the head of this bad cell, which is going to secrete all the mediators. Interestingly, long time ago, more than 20 years ago, it was known that elevated total IgE can be used as a first indicator for allergic asthma. So there was a correlation between the total IgE level and the asthma probability. Okay, this is interesting. This might not play a role when we treat. So when we treat, the serum IgE will be higher, will be lower. Doesn't have to do, but the more IgE we have, the more is the probability of having atopic asthma. And the IgE levels also correlate by several studies with the asthma severity. So the more we have an IgE, when you discover somebody with 1,000 of IgE, different than we discover somebody with 100 IgE. Both of them are still candidates for anti-IgE therapy, but literature has proven that the IgE levels correlate with the asthma severity. Omalizumab inhibits the IgE-mediated reactions. So omalizumab will bind the free IgE and will not allow it to start this cascade of degranulation, inhibits the effector cell sensitization. It will reduce the high affinity Fc alpha receptor 1, so on and so forth. It will reduce the mediator releases, and it will reduce the asthma symptoms and exacerbations. GINA guidelines recommend a stepwise. And when you are in the 4 and 5, then you are allowed to use the anti-IgE. So far, we do not prescribe anti-IgE for the mild asthma, which can be controlled by ICS or even low doses of ICS/LABA. But when you go higher to medium doses, then you should start thinking of course, you can add LAMAs, leukotrienes, whatever, but you should start thinking in atopic patients of the omalizumab. So what are the studies that have shown omalizumab efficacy? The experience registry a few years ago has made a clear cut on the effect of omalizumab in decreasing to actually trending toward zero exacerbations after 2 years of using omalizumab. And these patients, all of these patients, I have to admit, were significant, severe asthmatics who were difficult to control. 90% of patients were exacerbation-free after 2 years of omalizumab treatment. And, and this were the patients who had no clinically significant and no severe clinically significant. So these patients, after 24 years, around 90% did not have any exacerbations. The populations, interestingly, with both high levels of IgE and eosinophils, even may show an enhanced response with omalizumab. And this was a post-hoc analysis of the INNOVATE. And the INNOVATE study, as you know, was really one of the basic studies by Humbert a long time ago, and it had more than one follow-up. So IgE blockade also decreases IL-5 expression. And this was also by a study done recently, and this adds more to the efficacy of IgE blockade. IgE blockade decreases eosinophils in patients with asthma. And this also has been proven in more than one studies. The sputum and the blood eosinophils decrease with the IgE blockade. So IgE blockade also in one study have decreased the eosinophils in the lung tissue. And this was by Van Rensen, the allergy in 2009. They have decreased also the eosinophils, not only in the blood, but also in the lung tissues. So, according to the global evaluation of treatment effectiveness, there was 40% reduction of exacerbation response. I would say that this reduction exacerbation, give me something that decreases my exacerbations and give me something that decreases my oral corticosteroid dose. I would definitely use it in my patients. And I have to admit that omalizumab does both. It decreases my oral corticosteroids and it decreases significantly my exacerbations. The newcomers did not yet match with this thing as one-to-one, head-to-head, but omalizumab has done a great job in the past 20 years. It reduced exacerbations even in some studies up to 70%. And this is what we need in the patients with severe atopic allergic asthma. And this was irrespective of the eosinophil count. And this is again from the Stellar study, the recent one, that by Humbert also, which is the omalizumab effectiveness in patients with severe allergic asthma according to the blood eosinophil count. They found that it's irrespective of the eosinophil count, and the ones who had also high eosinophil counts were also in the same, positive response to the anti-IgE. So omalizumab therapy was effective in eligible patients with severe allergic asthma, irrespective of the pre-treatment blood eosinophil count. Blocking the IgE extends exacerbation protection over 6 years. And this is well known that you might get up to 70% of patients who continued treatment were free of exacerbations during the 6 years of treatment. And half of the patients who were discontinued after 5 years remained exacerbation free. GINA, as all of you know, recognizes the need to minimize oral corticosteroid use. So this is one of the also beneficial effects of anti-IgE therapy, because patients with severe asthma will have plenty of risks from the oral corticosteroids and adverse effects. We don't need to mention that the osteoporosis, the obesity, the anxiety, mental status, diabetes, all the other risk factors come from the chronic oral corticosteroid usage. So omalizumab reduces the requirements of oral corticosteroids, and it reduces it in some studies really statistically significant. So the reduction also in the experience registry in the real life was also quite favorable for the omalizumab on the maintenance of oral corticosteroid dose, especially after 1 year and then after 2 years of continuous treatment. Airway remodeling. This is also another thing which is also quite important in our severe asthmatics. They turn into COPD patients, and we have patients like this. We have asthmatics who are smokers or smokers who became asthmatics and whatnot, and they went into they went into fixed airway obstruction. This is not to scare us. This is not to scare us, but this is again why do we get the airway remodeling? I mean, this is it starts with the epithelial injury, which is also something that has been agreed by all the literature, and then we have the involvement of the dendritic cells. The neutrophil is there, the Th2 is there, the mast cell is there, and the eosinophils are there. And this complicated, relatively complicated thing, we have to learn from it that many cells are involved in remodeling of the airway smooth muscles and their thickness. So omalizumab, by working on all of this, all of the cells practically that cause the airway remodeling, should have a therapeutic efficacy and inhibition of the airway inflammation and remodeling. So it should finish by this. Omalizumab modulates bronchial reticular basement membrane thickness and eosinophil infiltration in severe persistent allergic asthma patients. Galectin-3 nowadays is being studied as an early predictive biomarker of airway remodeling, and omalizumab can affect this also bad marker with time. Proteomics of bronchial biopsy galectin-3 as a predictive biomarker of airway remodeling modulation in omalizumab treated severe asthma patients. Safety, of course, it has definitely a well-studied safety profile after 17 to 20 years. You might have some worries about the anaphylaxis, which we have discussed in many previous, occasions and so on. So we keep patients for, some time. It's an injection, so you have to observe the patient for an hour or two in the first, and then later we can, shorten this time. But of course, omalizumab has a very, very, very low incidence for troubles, but it is there, and we have to be careful about this. And this is what we are doing for years and years. The long-term treatment and the years of experience have been depicted by many, many, many real-world and other than real-world studies, but most of them are real-world studies. We have up to, literature up to 7 years. We have literature up to 9 years, and most of them, of course, were real life, and there were no safety concerns and no asthma-related hospitalization or emergency visits. So, what is going on nowadays? This is probably the last slide before I conclude. We have the uncontrolled severe asthma. We have to identify the phenotype and the endotype. And we have to go for the validation cross-sectional longitudinal studies. There is plenty of work to be done, plenty of future exciting and thrilling literature that is coming. I hope it will simplify, not make our life more difficult, but we have to be on the right track, all of us. Where do we use this biologic? How do we use it? And we have to, be on the safe side in all what we do in the future for our severe asthmatic allergic patients. So asthma endotypes and targeted treatment approaches. We have the allergic, non-eosinophilic asthma, and the targeted therapy is omalizumab. So this is also from a very recent review, and they suggest this algorithm. Does the patient require biologic? This is one of the main important questions. Don't go to biologic if the patient can be controlled by your usual medications. So asthma is not controllable, allergic or eosinophilic phenotype, or requires maintenance oral steroids. Yes, Then you go to are there asthma symptoms triggered by allergens, IgE level, and then if you have this, then you go into omalizumab sub-Q every 2 to 4 weeks based on the weight and the IgE level. If you don't have these criteria, then you are going down this algorithm to other biologic therapy. So take-home messages: severe asthma is a very heterogeneous disease. Several phenotypes and endotypes have been described by many important studies from Korea, from United Kingdom, from the severe asthma research, and elderly cohorts, image-based, as we said, microbiome clusters. There is no present system of subgrouping that achieves all the requirements. There are a number of comorbidities and co-founders which alter asthma phenotype. Longitudinal stability of phenotyping clusters was described to provide a systems approach for asthma personalized care. These data have to be integrated and reproduced longitudinally. Omalizumab is the first and for a long time the unique biologic drug registered for asthma. It's possible to remarkably improve, and when added to standard anti-asthma treatment, respiratory symptoms, quality of life, and exacerbations. Definitely we have studies, real life and placebo-controlled studies. It has the capability to blunt the allergic bronchial inflammation. It has a very good safety profile and can also interfere with the mechanisms for airway remodeling. Recent studies indicate that could potentially also be used in non-atopic severe asthma. This is something really interesting, but it's, probably will have to wait some time, and could widen then the, spectrum of use of omalizumab. The latest molecular developments leading to the generation of new anti-IgE antibodies can potentially provide further step forward in the modern treatment of atopic disease. By this, thank you for listening and ready for any question.
Thank you, Dr. Kanj, for being on time exactly. There are questions for you. What about omalizumab side effects?
Yes, omalizumab has been reported to have many side effects in the literature. As I said, I did not include the slide because of the time constraints. We have speculations about malignancy, which were not documented. We have speculations about thrombosis, which was not also quite important in the literature. We have, it was mentioned that in pregnancy, we have to say that omalizumab is, a type B. There were studies on some pregnants and it did not show any teratogenic effects. So the most, I would say, important adverse effect, as I said, and I mentioned this, is the possibility of anaphylaxis, which stipulates on us that when we give this injection, this patient should be in an area where we are equipped with the necessary equipment for this potential very rare complication. And this is what we are doing for the last 15 years.
Another question from the audience. We know that omalizumab dosage depends on the weight and IgE level. Do you think that in obese patients and very high IgE levels, other options of biological treatments is better to minimize the side effects of high dose of omalizumab?
Yeah. There is no first problem in the high dose of omalizumab, in a sense of high dose. We have given higher doses than usual. We have given 2 shots, every 2 weeks for patients with 1,300, 1,400 obese patients. If they are truly atopic, they don't have eosinophilic at all, I would definitely give these patients who are severely atopic allergic, I would definitely give them the trial of the maximum dose, and which can be little bit pushed, little bit more than the maximum dose, to make sure that their quality of life and their oral corticosteroid and exacerbations are much better. In case we are dealing with the type 2 low, then we have practically nothing much to offer these unfortunate patients, because these are usually the ones who are obese, smokers maybe, they don't have. In case we have the obese and the eosinophilic only, there is absolutely no IgE elevation, then we might definitely we will consider the new biologics.
Another question about the duration of the treatment with omalizumab.
Many years. We have used it on patients for many years, because when we stopped it, patients might have few months of exacerbation free and few months of excellent quality of life. But for some reason, of course, as known, patients might go back to their previous bad situation. Usually the standard is 6 months, and then we give them a break and see what's going on. But we have used it for years in certain patients.
I think that we have finished our time. Thank you, Dr. Kanj, for this comprehensive presentation, and thank you for the audience. And I think we finished the session, and you have a stretch break, and we will resume at 10 after 14.
It's given by the organizing committee.